Hey everybody, welcome back to the ECG channel. My name is Reed. Before we get started, feel free to go down into the description and download the PDF, which is this document of today's ECG, so that you can follow along, make your own notes, print it off, save it for later, have it to study, and subscribe to the channel if you like this content. I love making it. So let's jump into it. So I like to look at the forest when I initially look at ECGs, and the trees in my forest are my QRS complexes. What I'm saying is, let's just get a gist of what's going on with this rhythm. You can see I've got a narrow complex rhythm. Seems to be pretty regular. It's fast, but it's not too fast. And you can tell that it maintains this pattern throughout the entirety of the ECG. My rate here, if I zoom in on this QRS, it lands pretty much on a solid line. You can see the rate would be 300, 150, 100, just under 100. You can see it's just like maybe one little box past that. And so I'll just guess 95 beats per minute. So not too fast. So we've got a regular narrow complex rhythm. I just like to eyeball the rhythm and see, are there P waves? What do I expect? And I'm not really seeing P waves, and so that kind of kicks us off into thinking, well, what is this rhythm, right? And before we evaluate the atrial activity, we can go ahead and establish some pretest probabilities of what we think it's going to be. Well, we've got a narrow complex rhythm, so that tells me the narrow aspect of it, the width of the QRS is narrow, and that tells me that it's likely using the highway system that is our His-Purkinje system, where the AV node passes signal down quite rapidly to depolarize the ventricles. And so we know that rhythms that arise from the AV node or higher are typically would do this. And so this could be a rhythm that originates from anywhere at the AV node or higher, right? So kind of my initial thoughts. So let's look for the P wave. Let's see, what is the atria doing in this rhythm? So I like to look in front of my QRSs and see, I don't really see P waves there, but that's only one lead. Let's look at all the different leads. AVF, I don't see any. V1, if I don't get anything there, I'll scan through to V1. Why do I like V1 for my atrial activity? Well, if you look here, the T waves are pretty, typically V1 has the most flat T waves. And so, first thing I see is that there are no P waves. Okay, so the sinus node doesn't seem to be what is driving this rhythm. Well, what is? And so if there are no P waves, it means it's not an ectopic rhythm. I don't see any P's that are superimposed on my T's here. And so that's what's kind of good to scan through the lead. So I don't see any P waves driving this rhythm. But I've got a narrow complex rhythm that's arising from the junction. And so what is my differential for something that doesn't have a P wave? Well, this can maybe be atrial fibrillation, right? Atrial fibrillation doesn't have distinct P waves. This could be coming from the junction, like a junctional rhythm. And for AFib, a couple things I would see. Sometimes in AFib you can see very fine fibrillatory waves. Here you don't see any. But what I would expect in AFib, because in AFib we've got this sporadic signal that is just heading through the atria, and the AV node is a bystander sending that signal down at a regularly irregular fashion. Here we've got such a regular rhythm that I would say AFib is highly unlikely. We would see some irregularities. The AV node is not perfect whenever it comes to AFib. And so since we really eliminate that, we would say this is coming likely from the junction. So there's some focus kind of right here, we do it in black, right here from the junction that's firing off, that is depolarizing our ventricles. And so we would call this an accelerated junctional rhythm. And so you say, well, why accelerated? Well, we know that the AV junction, right here, the AV junction has the ability to create its own kind of pacing if needed. However, typically that's done, we'll do a different color. Typically, the AV junction can do that at a rate of only 40 to 60 beats per minute. Here we see it's doing it at a rate of 95 beats per minute. So because of that, it's a junctional rhythm, but it's not a junctional escape, it's an accelerated junctional rhythm because it's going faster than what it typically would behave. So this is an abnormal behavior. So we've got an accelerated junctional rhythm. Well, what are some features of an accelerated junctional rhythm? Well, one thing is the QRS complex should be kind of typical of a normal QRS. So let's evaluate that QRS, right? We can't evaluate the PR interval because there's no P wave. And so let's evaluate our QRS. We can see we've got upright QRSs in lead 1. We've got upright QRSs in AVF. That tells me that signal is going down and to the left. That vector of ventricular depolarization is going down to the left, and that's normal. So my axis is normal. And there's really something kind of neat about junctional rhythms that I think are kind of fun to discuss. So sometimes, and some people have the ability to have something called retrograde conduction. So some people can have retrograde P waves. What do I mean by that? Well, imagine we've got this junction right here. It's firing off. Not only is it sending signal down into the ventricles, but it also is sending signal potentially backwards and causing retrograde depolarization of the atria. In a junctional rhythm, this occurs almost simultaneously, right? Whenever this junction fires off, we've got signal going up and down at the same time. We know that that signal going down is going to have a large amplitude because our ventricular myocardium is thick and strong, versus our atria is kind of thin and wimpy in comparison. And so we know that's why P waves are smaller. So our retrograde P waves are occurring at the same time as our QRS. Well, I can see a little bit of that evidence in AVR. So look at AVR, and you see this kind of upward deflection at the end of that QRS. If I could draw it on there for you, that deflection, that little notch, that's kind of like an R prime. It's kind of like an R prime, right? It's a late R. And that tells me that there are late forces heading towards AVR. We know that since AVR is situated kind of on this side, on the upper right, that is actually evidence of retrograde atrial activation heading towards AVR. And so that happens right at the end because this focus fires off, sends signal down to the ventricles, and then just takes a little bit longer to make its way through the AV node back into the atria. And so we get a little bit of that late R prime, those late forces in AVR. We can sometimes call that a pseudo R. You can also see that sometimes in V1. We don't see that here. So that pseudo R even just gives us more data that this is really a junctional rhythm. This is something associated with that AV junction. And so, the rest of our QRS, right, we've got, seems to be decent R wave progression here. It transitions around V3, V4. Pathological Q waves, looking for previous myocardial infarctions that are evidenced by pathological Qs. I don't see any deep Q waves. I don't see any ST or T wave changes that would be, elevation, depression, T wave inversions that are really scary for me. And before I put this all together, I go, okay, let me just make sure one more time that I know this is a junctional rhythm, right? We're making important decisions in the clinic. Are you going to send this person to the EP lab? Are you going to treat them for an AV block? I need to make sure that the diagnosis is clear before I send this person home. And so I really look one more time, nice and good for P waves. I look in the T waves for P's. I just scan through all these leads, and I look all through. I'll look through V5. I'll look through V6, and I'll look through lead 3. I don't see any. So I don't see any atrial activation, just to make sure. And so now that we've done all that, we've diagnosed this person, we can put this all together and be diagnostic with this ECG. So do it. So we've got an accelerated junctional rhythm at a rate of 95 beats per minute. And we've got some, if you even want to say, with some evidence of retrograde atrial activation. So hope this helps. If you have any questions, throw them in the comments. I think it's important for this to just develop an anatomic framework like we did, right? We understand, deeply understand normal conduction through the cardiac system and the properties of the electrical tissue that the heart, has at certain levels. And so by doing that, we can really kind of weave our way in and out of this rhythm to understand what's going on. Because these decisions are important, right? And this patient needs to have a disposition that's appropriate for their disease. So hope this helps. If you have any questions, throw them in the comments. If not, we will see you at tomorrow's video. Have a great day.